Women with cardiovascular disease that present at a young age not only have different causes of their chest pain, they may have differences in the type of symptoms they have. For example, I think classically people think of heart disease pain as like a crushing pain or an elephant sitting on one's chest, and it can be much more subtle than that.
Yet there's a proportion of people, estimated around 5 to 15% of people, who will come in with an acute heart attack, and we'll take them to the cath lab for an angiogram, trying to look at their coronary arteries, and we don't find any blockages. We don't see any obvious reason why they're having a heart attack. And this is a growingly recognized area within cardiology. It's a class of heart attacks that we're now terming as MNOCA. Stands for myocardial infarction, which is just another word for heart attack, with non-obstructive coronary artery disease. So heart attacks that don't have obvious blockages, cholesterol blockages in the arteries to explain them. Women are twice as likely to have this type of heart attack when they come in with acute chest pain.
So women may have an uneasiness or a discomfort or any unusual feeling anywhere in the jaw, neck, shoulders, arms, left or right side. Could be more of a numbness, may be associated with shortness of breath or feeling weak or sweaty. And so they don't always associate it with a typical blockage pain. And one of the reasons it may present different is because the causes of the pain may be different in men and women. So in some cases, because women are presenting with different symptoms, it can lead to a misdiagnosis, or they can be dismissed as not having cardiac pain.
Traditionally, they've been diagnoses of exclusion. We say, well, you don't have this, you probably have this. Without that confirmatory test, we're really limited in our ability to do additional research on therapies, on outcomes, on mortality, on how to make people better.
So this field is really, in a sense, at an infancy, even though it's been recognized for decades. For blockages of cholesterol, we have very effective therapies like statin therapy, and we can put in stents or offer bypass surgery, and that will rapidly improve someone's quality of life and decrease their risk of a heart attack or dying of heart disease. When they have other forms of heart disease that affect, say, the microvasculature or smaller blood vessels, we don't have the research we need to guide us as to how to reduce risk in those patients. I'm really confident that with the right education, and if we can get donors to support implementation of these new tools to diagnose women's heart disease, that we will really improve the outcomes of women in our community.